Good afternoon. Today I would like to introduce you the next pharmacology lecture, Drugs Acting on Renal System. Lecture plan: General considerations, diuretic agents and related drugs increasing diuresis, antidiuretics. Let's start from general considerations. Definitions: Diuretics are various agents that increase daily excreted volume of urine, enlarge diuresis. Mercury-containing drugs were the first to use like remedies, which can decrease edema. In 1937, carbonic anhydrase inhibitors were first described that increase total daily volume of urine excretion. In 1957, chlorothiazide, more powerful diuretic, became available. Term diuretic is used to indicate all drugs that increase urine volume, whereas natriuretic drugs increase in renal sodium excretion and aquaretic drugs increase excretion of solute-free water. Kidney. Nephron, from Greek nephros, is a structural functional unit of the animal's kidney. The nephron consists of a body where filtration occurs and a system of tubules in which reabsorption or reuptake and secretion of substances take place. Nephron regulates blood pressure, controls electrolyte levels and metabolites, and also participates in maintaining a constant pH level. Nephron is also an endocrine gland that synthesizes steroid hormones such as antidiuretic hormone, aldosterone, and parathyroid hormone. Nephron is an epithelial structure, which is a system of convoluted and direct tubules that blindly begin with a capsule from the vascular glomeruli of each renal organ and flows into a combined tube. Approximately each kidney contains 2 million of nephrons. Structure of nephron. First is kidney body, which contains vascular glomerulus or glomerula and glomerulus capsule, Shumlansky-Bowman capsule. Second, renal tubules, which contains proximal tubule, loop of Henle. Loop of Henle is subdivided into descending limb of Henle's loop and ascending limb of Henle's loop, and distal convoluted tubules. Third, collecting tubules, and fourth, justoglomerular apparatus. Filtration, reabsorption, and secretion. Primary urine. All components of blood plasma, salts, amino acid, glucose, and other substances, in addition to proteins, also urea and uric acid. Primary urine is a filtered blood plasma without proteins. Daily, 150 to 180 liters of primary urine is formed. In this process, all soluble components come out from the blood. Blood cells and proteins are not filtered. Reabsorption into tubules, formation of secondary urine. Reverse absorption of water, amino acids, glucose, vitamins, sodium, potassium, calcium, chloride ions from the primary urine. Primary urine from the capsule enters the renal tubule where reabsorption occurs. From the loop of the nephron or Henle's loop or loop of Henle to the blood returns water and mineral salts in the required amount. In the result of reabsorption, 99% of the volume of the primary urine returns to the blood again. Harmful substances such as urea are almost not absorbed back into the bloodstream and therefore are excreted from the body. Secretion from the blood is actively transported in the tubules. Water, potassium ions, hydrogens, components of drugs, uric acid, ammonia, hydrogen ions, medicinal substances, etc., which have entered the blood, are withdrawn back into the renal tubules. The purified blood passes into venules that merge into the renal vein, which carries blood from the kidney, restoring the constancy of the blood composition. And to the collecting tube comes a fluid 10 times more concentrated, which is called secondary urine. From the combined tube to the secondary urine is collected in the renal ball, which is excreted in the urinary tract from the body. During the day, from 150 to 180 liters of primary urine, about 1.5 till 1.8 liters of secondary urine is formed. In here you can see the composition of plasma of blood, primary and secondary urine in percent by weight. For example, substances as water, proteins, glucose, sodium ions, potassium ions, chloride ions, urea and uric acid, and their content in blood plasma, primary urine and secondary urine. On this slide you can see the process of blood filtration in the nephron. A is the kidney body, B proximal tubule, C distal convoluted tubule, D juxtaglomerular apparatus. Under 1 we see basal membrane, under 2 Shumlansky-Bowman capsule parietal plate, under 3, specifically 3A, we see legs of podocyte, under 3B we see podocyte itself, under 4 the space of Shumlansky-Bowman, 5A mesangial intraglomerular cells, 5B mesangial extraglomerular cells, 6 granular juxtaglomerular cells, 7 dense spot, 8 myocyte, 9 priori arteriola, under 10 foliage capillaries, and 11 extracting arterioles. Blood flows into the arteriole at the top and from the outer arterioles below. Blood flows through the capillaries of the glomerulus, where it is filtered through pressure. The podocyte in here cover the capillaries. The blood is filtered through the filtration cleft between the legs of the podocytes in here. The filtered urine passes through the proximal tubule to the right. Urine formation is based on main 4 sites. Site 1, proximal tubule, main sodium transport. Site 2, ascending limb of Henle's loop. Site 3, cortical diluting segment of Henle's loop. Site 4, distal tubule and the collecting duct. In here you can see 4 sites of salutary absorption which I mentioned before. In here site 1, in here site 2, in here site 3, and in here site 4. The thick ascending lip of Henle's loop is impermeable to water. Site 1, proximal tubule, 4 mechanisms of sodium transport. A. Direct entry of sodium along electrochemical gradient. This is electrogenic. B. Transport of sodium and potassium coupled to active reabsorption of glucose, ammonium acids, other organic anions and phosphates through specific symporters. Only the glucose-coupled sodium reabsorption is electrogenic. C. Secretion of hydrogen with the help of sodium-hydrogen antiporter, sodium-hydrogen exchanger in the luminal membrane. And D. Passive drive of chlorides due to disproportionality, large hydrocarbonates, amino acids, acetate, phosphates reabsorption. On this slide you can see the carbonic anhydrase mediated bicarbonate absorption in proximal tubule and 2 types of carbonic anhydrases, second and fourth. Site 2, ascending or thick limb of loop of Henle. Portions of medullary part lined by cuboidal cells. A distinct luminal membrane carrier transport ions in the stoichiometric ratio of sodium, potassium to chlorides and is non-electrogenic. The sodium that enters the cell is pumped to the extracellular fluid by sodium-potassium ATPase at the basolateral membrane. In addition, sodium chloride symporter moves chlorides down into electrochemical gradient into extracellular fluid and carries sodium along. And cortical part lined by flattened cells. And in here you can see mechanism of salt reabsorption in the thick ascending limb of loop of Henle cell and site of action of furosemide on the sodium-potassium 2-chloride cotransporter. Site 3. Cortical diluting segment of loop of Henle. Cortical diluting segment of loop of Henle, also impermeable to water, continues to absorb salt, but here it is through sodium-potassium chloride symporter. Tubular fluid gets further diluted. And site 4. Distal tubule and collecting duct. Sodium is again actively reabsorbed, the cation-anion balance being maintained partly by passive chloride diffusion and partly by secretion of hydrogen and potassium. Absorption of sodium at this site occurs through a specific amiloride-sensitive sodium channel and is controlled to a large extent by aldosterone. And in here you can see mechanism of salt reabsorption in early distal tubular cell and site of action of thiazide diuretics on sodium chloride symporter. And on this slide you can see site and mechanism of action of potassium sparing diuretics on the late distal tubule collecting duct cell. Aldosterone penetrates the cell from the interstitial side and combines with the mineralocorticoid receptor, MR. The complex translocates to the nucleus, promotes gene-mediated mRNA synthesis. The mRNA then directs synthesis of aldosterone-induced proteins, AIP. The AIPs include sodium-potassium ATPase and renal epithelial amiloride-sensitive sodium channels. More of these proteins are synthesized. The AIPs also activate these sodium channels and translocate them from cytosolic site to luminal membrane. They also translocate sodium-potassium ATPase to the basolateral membrane. AIPs also increase ATP production by mitochondria. All these changes promote sodium reabsorption. More potassium and hydrogen is secreted indirectly. Spironolactone binds to mineralocorticoid receptor, prevents aldo action, and produces opposite effects. Amiloride approaches sodium channel from the luminal side and blocks it, reducing the lumen-negative transepithelial potential difference, which governs potassium and hydrogen secretion. And on this slide you can see apical membrane, sodium-hydrogen exchange, and bicarbonate reabsorption in the proximal convoluted tubule cell. Sodium-potassium ATPase is present in the basolateral membrane to maintain intracellular sodium and potassium levels within the normal range. Because of rapid equilibration, concentrations of the solutes are approximately equal in the interstitial fluid and the blood. Carbonic anhydrase is found in other locations in addition to the brush border of the luminal membrane. In here you can see ion transport pathways across the luminal and basolateral membranes of the thick ascending limb cell. The lumen-positive electrical potential created by potassium back diffusion drives divalent and monovalent cation reabsorption via the paracellular pathway. Sodium-potassium 2-chloride cotransporter is the primary transporter in the luminal membrane. And on this slide you can see ion transport pathways across the luminal and basolateral membranes of the distal convoluted tubule cell. As in all tubular cells, sodium-potassium ATPase is present in the basolateral membrane. Sodium and chloride cotransporter is the primary sodium and chloride transporter in the luminal membrane. In here you can see ion transport pathways across the luminal and basolateral membranes of collecting tubule and collecting duct cells. Inward diffusion of sodium via the epithelial soluble channel leaves a lumen-negative potential, which drives reabsorption of chlorides and efflux of potassium. And on this slide you can see water transport across the luminal and basolateral membranes of collecting duct cells. Low water permeability exists in the absence of antidiuretic hormone, ADH, arginine vasopressin. Presence of ADH, aquaporins are inserted into the apical membrane, greatly increasing water permeability. Mayer segments of the nephron and their functions. In here you can see different Mayer segments, for example, glomerulus, proximal convoluted tubule, proximal tubule straight segments, thin descending limb of Henle's loop, thick ascending limb of Henle's loop, distal convoluted tubule, cortical collecting tubule, medullary collecting duct, and their functions: water permeability, primary transporters and drug targets at apical membrane, and diuretic with major action. The next part of our lecture is diuretic agents and related drugs increasing diuresis. Diuresis, volume of urine formed over a certain period of time. In nephrology practice, the most commonly used measurement is daily diuresis, the volume of urine recovered in 24 hours, and also minute diuresis, the value of which is used in the study of renal function by the clearance method. So the first, tubular reabsorption forming the final content of urine. In normal conditions, diuresis volume is 1.5, 1.8 up to 2 liters for 24 hours. During the day, average 180 liters of water is reabsorbed. In this, 99% of primary urine is reabsorbed into blood circulation, 80% of sodium and potassium, 80–90% of inorganic phosphorus, 90% of hydrocarbonate, and glucose, 9 millimole renal glucose level. And second, tubular secretion, mostly in proximal segment, provide active elimination of large parts of the biochemical metabolite. Ammonia in forms of final biological compounds, other final endogen compounds, xenobiotic compounds, pharmacology compounds and their metabolites, potassium ions, passive, hydrogen ions, active, are also secreted in tubuli. Diuretics are various agents that increase daily excreted volume of urine, increase diuresis. The term diuretic is used to indicate all drugs that increase urine volume, whereas natriuretic drugs increase in renal sodium excretion and aquaretic drugs increase excretion of solute-free water. Diuretics are presented by drugs acting as soluretic agents, potassium-sparing agents, osmotic diuretics, activators of blood circulation, and other agents providing diuretic effect. So on this picture you can see the site of diuretic effect of different specific drugs: acetazolamide, osmotic agents mannitol, loop agents furosemide, thiazides, aldosterone antagonists, antidiuretic hormone antagonists, and adenosine. Classification of diuretics due to acting mechanism. First, drugs acting on the level of tubule, subdivided into 1. Level of apical membrane, competitive with sodium ions in bond transferring agents, especially with beta transfer protein. Triamterene, amiloride are blocking beta transfer protein. And next, aldosterone antagonists, blocking synthesis of beta transfer protein. Spironolactone, canrenone, eplerenone. Aldosterone, principal regulator of the water and salt balance of the body, and thus is categorized as a mineralocorticoid. Next, 1–2. Level of basolateral membrane. Carbohydrase inhibitors, acetazolamide. Next, benzothiazepine derivatives, thiazides, hydrochlorothiazide, chlorothiazide, cyclothiazide, cyclopenthiazide, and oxodoline. Next, bis-chlorphenoxyacetic acid derivatives, ethacrynic acid. And one more, antranilic acid derivatives, furosemide, bufenox, clopamide, toracemide. In here you can see thiazides and related diuretics, inhibitors of sodium and chloride symport, chlorothiazide, hydrochlorothiazide, indapamide, metolazone. Clinical indications of thiazides: hypertension, heart failure, hypercalciuria, hyperkalemia, diabetes insipidus. Side effects of thiazides: hypokalemia, hyponatremia, metabolic alkalosis, hypercalcemia, hyperglycemia, hyperuricemia, hyperlipidemia, sulfonamide allergy. In here you can see the details about thiazides and related diuretics. For example, bendroflumethiazide, chlorothiazide, chlorthalidone, hydrochlorothiazide, hydroflumetazide, indapamide, methiclothiazide, metolazone, polythiazide, quinetazone, trichlormethiazide, their total daily oral dose, and frequency of daily administration. Next one is loop diuretics, for example, furosemide and etacrinic acid. Clinical indications of loop diuretics: hyperkalemia, heart failure, hypertension, acute renal failure, anion overdose. In here you can see typical dosage of loop diuretics. For example, bumetanide, etacrinic acid, furosemide, and torsemide, and total daily oral dose. Next one is potassium-sparing diuretics, spironolactone amiloride. Clinical indications of potassium-sparing diuretics: hypokalemia, hyperchloremic metabolic acidosis, gynecomastia, renal failure, kidney stones. And on this slide you can see potassium-sparing diuretics and combinations. Please pay attention that these drugs are in trade names. For example, aldactazide contains spironolactone 25 mg and hydrochlorothiazide 50 mg. Aldactone, spironolactone 25, 50 or 100 mg. Diazide, triamterene 37.5 mg and 25 mg of hydrochlorothiazide. Diurenium, triamterene 50 or 100 mg. Inspra, eplerenone 25, 50 or 100 mg. Maxzide, triamterene 75 mg and 50 mg of hydrochlorothiazide. Maxzide 25 mg. Triamterene 37.5, twice less, and hydrochlorothiazide 25 mg, also twice less. Midamor, amiloride 5 mg, and Diuretic, amiloride 5 mg and 50 mg of hydrochlorothiazide. Next group is carbonic anhydrase inhibitors. Their clinical indications: glaucoma, urinary alkalinization, metabolic alkalosis, acute mountain sickness, other clinic cases of diuretic needed. In here you can see carbonic anhydrase inhibitors used orally in their specific indication, which is glaucoma. For example, dichlorphenamide, 50 mg 1-3 times a day, and metazolamide, 50 to 100 mg 2-3 times a day. And one more group, osmotic diuretics, for example, mannitol, urea pura. They are given intravenously with isotonic 0.9% solution of sodium chloride as the vehicle. Please remember this. Clinical indications of osmotic diuretics. They have got one very interesting specific indication: tissue edemas, slow dehydration. One more group, extrarenal agents releasing their action due to increasing whole and especially renal blood circulation. In here we have xanthines, theobromine, theophylline, and euphylline. And one more additional group, herbal and plant derivatives. In here you can see some different plants which also provide weak diuretic effect. So now let's classify those diuretics due to action power. First, we have high-efficiency diuretics, inhibitors of sodium-potassium 2-chloride cotransport. For example, furosemide, bumetanide, torsemide. Second, medium-efficiency diuretics, inhibitors of sodium chloride symport. Thiazides, hydrochlorothiazide, benzthiazide, hydroflumethiazide, bendroflumethiazide. Thiazide-like diuretics, chlorthalidone, metolazone, cipamide, indapamide, clopamide. And third, weak or adjunctive diuretics, carbonic anhydrase inhibitors, acetazolamide, Potassium-sparing diuretics, which are subdivided into aldosterone antagonists, spironolactone, eplerenone, and inhibitors of renal epithelial sodium channels, triamterene amiloride, and osmotic diuretics, mannitol, isosorbide, glycerol. The other type of classification is classification of diuretics due to the time of diuretic effect release. First is a rapid, urgent acting effect release in 30-40 minutes, furosemide, etacrinic acid, triamterene, sometimes combined with mannitol, urea. Second, average effect release in 2-4 hours, acetazolamide or diacarb, theophylline, nepheline, amiloride, cyclometiazide, clopamide, oxodoline, and slow acting effect release in 2-4 days after intake, spironolactone. And third classification is rating of diuretics due to duration of diuretic effect. Short acting, duration 4-8 hours, furosemide, etacrinic acid, triamterene, mannitol, urea. Average duration during 8-14 hours, acetazolamide or diacarb, triamterene, amiloride, cyclometiazide, hydrochlorothiazide, Dix, theophylline, nepheline, and long-lasting for several days, oxodoline and spironolactone. And in here you can see changes in urinary electrolyte patterns and body pH in response to diuretic drugs. For example, group carbonic anhydrase inhibitors increase sodium chloride, vary increase sodium hydrocarbonates, increase potassium, and provide acidosis. Loop agents, you can see 4 pluses, so it is very increase of sodium chloride, no change in sodium hydrocarbonates, little increase in potassium, and alkalosis. Thiazides, increase sodium chloride, little increase sodium hydrocarbonate, increase potassium, and provide alkalosis. Loop agents plus thiazides, very powerful increase in sodium chloride, little increase in sodium hydrocarbonates, increase in potassium, and alkalosis. And potassium-sparing agents, little increase in sodium chloride, little increase in sodium hydrocarbonates, decrease in potassium, and provide acidosis. Renal function quality determined by creatinine clearance. Normal value of creatinine in blood from 50 to 100 micromole per liter, or 0.6 to 1.2 milligram deciliter, or 6 to 12 milligrams each liter. Normal creatinine of clearance 90 to 130 milliliter minute, 1.73 square meters body surface, decreasing in cases of renal pathology. Naturally decreasing by age, average 1% each next year after 40 years of age. Renal autocoids, locally produced compounds which exhibit physiologic effects within the kidney are referred to autocoids or paracrine factors. These are adenosine, prostaglandins, peptides, acting on kidney function. And the last part of our lecture is antidiuretics. Antidiuretics, more precisely antiaquaretics, because they inhibit water excretion without affecting salt excretion, are drugs that reduce urine volume, particularly in diabetes insipidus, which is their primary indication. Drugs are antidiuretic hormone, with which we met before, vasopressin, desmopressin, lipressin, terlipressin. Second, thiazide diuretics, amiloride. And third, miscellaneous, indomethacin, chlorpropamide, carbamazepine. Antidiuretic hormone, hormone secreted by posterior pituitary, narrow hypophysis. Rate of antidiuretic hormone release controlled by osmoreceptors present in hypothalamus, volume receptors present in left atrium, ventricles, and pulmonary veins. Physiological stimuli for antidiuretic hormone release, rise in plasma osmolarity, contraction of plasma extracellular fluid volume. Antidiuretic hormone receptors. V1 receptors at all sites except 4 sites of V2 collecting duct cells, further classified as V1A and V1B. V1A, vascular smooth muscles, including that of vasa recta in renal medulla, uterine, visceral smooth muscles, interstitial cells in renal medulla, cortical CT cells, adipose tissue, brain, platelets, liver, etc. V1B, anterior pituitary, certain areas in brain and in pancreas. V2 receptors are more sensitive. Collecting duct principal cells in kidney regulates their water permeability, also activates sodium-potassium 2 chloride cotransporter, endothelium vasodilator. Antidiuretic hormone action on various organs. First of all, kidneys. Acts on CD principal cells, renders them water permeable, water absorbed, concentration urine passed, equilibrating with hyperosmolar medulla. Blood vessels, constricts through V1 receptors, raises blood pressure, dilates through V2 receptors, endothelium dependent NO production. GIT, increased peristalsis, evacuation and expulsion of gases. Uterus, contracted by acting on oxytocin receptors. Central nervous system, endogenous AVP may be involved in regulation of temperature, systemic circulation, adrenocorticotropic hormone release, learning of tasks, and others, induces platelet aggregation, hepatic glycogenolysis. Release of factor VIII and von Willebrand factor for vascular endothelium, V2 mediated. Antidiuretic hormone mechanism of action. V2 receptors. Principal cells of collecting duct, increased aquaporins expression leading to increased water absorption, decreased urine formed. Augmented by concurrent decrease in endocytosis and degradation of aquaporins. Continued stimulation leads to increased production of aquaporins, increased vasopressin-regulated urea transporter expression in terminal CD cells, increased medullary hypertonicity, increased water absorption, decreased urine formed. Increased translocation and synthesis of sodium-potassium 2 chloride channels in ascending limb of loop of Henle, increased medullary hypertonicity, concentrated urine formed. V1 receptors, constricts vasa recta, diminished blood flow to inner medulla, reduces washing off effect and helps in maintaining high osmolarity, contributing to antidiuresis. Vasopressin analogs, for example, lipressin, terlipressin, and desmopressin, and their description. Uses of antidiuretics. Based on V2 actions, diabetes insipidus, neurogenic, bedwetting in children and nocturia in adults, renal concentration test, hemophilia, von Willebrand's disease. Based on V1 actions, bleeding esophageal varices, before abdominal radiography. Vasopressin adverse effects. Selective drugs produce lesser side effects. Transient headache and flushing frequent. Local application, nasal irritation, congestion, rhinitis, ulceration, epistaxis. Systemic side effects. Belching, nausea, vomiting, abdominal cramps, pallor, urge to defecate, backache in females, uterine contraction. Fluid retention, hyponatremia. Bradycardia, increased cardiac afterload, precipitate angina. Contraindicated in patients with ischemic heart disease, hypertension, chronic nephritis, psychogenic polydipsia. Thiazides, hydrochlorothiazide, provide paradoxical effect. Furosemide, effective but less desirable, short and brisk action. Effective in both neurogenic as well as nephrogenic diabetes insipidus. Mechanism of action, similar to salt restriction, state of sustained electrolyte depletion, glomerular filtrate completely reabsorbed isoosmotically in PT, urine passing has low solutes, presented to cortical DT, salt reabsorption decreases, less dilute urine presented to CD, same is passed out. And second, reduces glomerular filtration rate, reduced fluid load on tubules, amiloride, lithium-induced nephrogenic diabetes insipidus. Other antidiuretics, indomethacin, reduces renal prostaglandin synthesis, reduced polyuria in nephrogenic diabetes insipidus. Combined with thiazide plus minus amiloride, other NSAIDs less effective. Chlorpropamide, long-acting sulfonylurea oral hypoglycemic, effective in neurogenic diabetes insipidus, sensitizes kidney to antidiuretic hormone. Carbamazepine, as an anti-epileptic, effective in neurogenic diabetes insipidus, higher doses needed, marked adverse effects. And the last part of our lecture is examples of MCQs. A patient with hypertensive crisis should be administered a diuretic as the part of complex therapy. What drug should be given to a patient? As it is hypertensive crisis and you should act very quickly, you must find the quickest acting diuretic, which in this case will be furosemide. The usage of dichlorothiazide, a tacrinic acid, and furosemide didn't cause marked diuretic effect in the patient with marked peripheral edemas. The aldosterone level in the blood is increased, indicate which medicine should be prescribed. In this case, the specific hint is aldosterone level in the blood is increased and that none of other diuretics provided marked effect. So you must find a drug which is acting on aldosterone. From all the options, it will be spironolactone. Diuretic agent in dosage 25 mg 2 times a day had been prescribed to the patient at the beginning stage of idiopathic hypertension. In 7-8 days, the arterial pressure has slightly decreased, but he began to complain of pain in the heart region, muscle weakness, and tremor. The analysis of blood has revealed hypokalemia, which from the listed drugs may cause this side effect. Please be very careful with this hypokalemia because you will meet with it in many different MCQs. But from all options, only hydrochlorothiazide can cause hypokalemia and is taken or may be taken in the dose 25 mg 2 times a day. A patient admitted with heart failure who is taking a thiazide diuretic has been ordered to receive furosemide or trade name Lasix. What side effect of these medications should a doctor be alert for? Again, the story about hypokalemia, because and furosemide and thiazide diuretics provide hypokalemia. So in this case, it will be even more in this kind of combination. So the side effect is hypokalemia. A reduction in insulin release from the pancreas may be caused by which of the following diuretics? It is also very interesting MCQ, and the specific answer in here is hydrochlorothiazide also. Thank you for your attention.